I'm pleased to be able to welcome you to this colorectal cancer session. We have a very esteemed group of speakers here on the podium, and we're looking forward to hearing from everyone. In past years, we've had fewer speakers, so we're going to need to condense our talks a little bit. And there's also a session in this room, I think, starting at 11:30. So we each are going to try to keep it to around 15 minutes per talk, and obviously with the opportunity for questions and answers, and even afterwards, if you have any issues or questions that you'd like to address to any of us, we'd obviously be more than happy to. You can just find us, and we're delighted to assist in any way that we can. This is a very timely meeting from my point of view, because just in the last couple of weeks, there's been some major news in the world of colon cancer, colorectal cancer, and screening. For those of you who are familiar with the medical news that's been proliferated just within the last 2 weeks, what I'm sure will be a landmark study was published in the New England Journal of Medicine, and you may have read about it anywhere in your local newspaper as well. Demonstrating something that I think we all expected would be the case, but now I think we have a fair amount of evidence for. A group that terms itself the National Polyp Study had previously shown that colon cancer screening with colonoscopy can decrease the incidence of colon cancer. And now, with much longer follow-up, that group has shown fairly convincingly that it also decreases mortality significantly. In this group of patients who were followed for, in some instances, as long as 23 years, patients who underwent colonoscopy and had adenomas, polyps removed from their colon, had a 53% reduction in mortality compared to what would have been expected if they had not. So this is great news for the world of colon cancer prevention, obviously, and just thought I'd share it with everyone because I think it's relevant to our talk today. Now, with regard to what we're going to talk about today, just one more word about screening. This slide, I think the previous slide just make this slide a little bit out of date in terms of the cost effectiveness question. Because I think we're going to find maybe now even that colon cancer screening is going to be even more cost effective. As you can see here, while it's somewhat pricey, it's actually cheaper in terms of preventing cancer than some other, perhaps somewhat more popular screening techniques, things like breast cancer screening or the use of airbags in cars. So this is not something that's pie in the sky. This is something that's real and that is truly cost effective. Now, a lot of you already know some of these statistics. I'm not going to dwell on statistics at all, but just to remind everyone, these data are a few years old, but there's over 150,000 new cases of colorectal cancer diagnosed each year. Most of them are in the colon, but a significant minority in the rectum. And the good news is a lot of patients are able to undergo surgery for potential curative resection of their cancers. But for those who have stage 2 or stage 3 disease, it's very important that following treatment, that some sort of surveillance program be put into place because of the possibility of recurrence. And the goal, of course, in these instances is to try to detect any recurrence, again, for the purposes of curative treatment. There have been a variety of strategies that have been published in the literature. And again, without belaboring the point, the goal after treatment successfully of a colon cancer, particularly with surgery, would be to prevent, to find a recurrence if it's there, and then to treat it successfully, ideally with surgery, but potentially with other modalities as well, as you are, of course, going to hear about. So for those people who've had stage 1 colon cancer, there is obviously a very high cure rate, and for those patients, there is not necessarily or not clearly defined surveillance program recommended. But for those who've had slightly more advanced stages, stage 2 and 3 cancers, early diagnosis is important to potentially yield better outcomes in terms of further treatment. One of the reasons is because of the incidence of liver metastasis in some of these patients. And I think 20 years ago, this was kind of a bizarre concept that people didn't really imagine would have evolved the way that it has. But patients who've had limited spread of their tumor to their liver, and in some instances to their lung, can undergo resection of those tumors with an absolutely remarkable improvement in survival. So this is one of the true benefits that have been yielded from this surveillance program and from the advances that have taken place over the past couple of decades. It may stand to reason, but it's also been shown that earlier detection of any recurrence yields potentially to better outcome. Not surprising that if you're symptom-free and a recurrence is detected, that you perhaps are more likely to get a recurrence picked up at an earlier stage and potentially a more treatable stage. But even patients who have symptoms, when a recurrence is detected, a significant minority of those patients still have the opportunity to potentially have a resectable process. A number of different tools have been used to survey patients who've been treated once for colon cancer to look for recurrence. I listed a whole variety of them here, but in red you can see the ones that we tend to use most frequently and the ones that perhaps have the most data to support their use, including the CEA levels, the CT scanning, and endoscopy, which I'll go through to some extent. The reason that it's important is because if you've had colon cancer once, the risk of getting colon cancer a second time or of having colon cancer develop at the site of the previous resection is elevated compared to those just in the general population, as you can see here. It's not happily as frequent as the risk in patients with other higher risk conditions, like patients who've had ulcerative colitis for more than 10 years or 20 years, or patients who have hereditary colon cancer syndromes. But it's still significant, and surveillance is warranted under those circumstances. When recurrences do occur after initial treatment, they tend to occur within the first 5 years or so after the initial treatment, and most of those are in the first couple of years or 3 years. And I mentioned the issue of the liver metastasis, so this again is more support for the use of surveillance. I mentioned a few minutes ago the CEA test, which is the circulating protein in the blood, which doesn't have, unfortunately, much use in screening for patients for colon cancer in the first place, but for those who've had colon cancer, there is potential value in some patients, particularly those who have an elevated CEA at the time of their diagnosis. And this could potentially prompt a more vigorous search for a recurrence, and therefore it's very important. And although studies may have suggested that it may not be quote-unquote cost-effective, it certainly is recommended at this stage to be checked every 3 to 6 months or so. Perhaps our oncologist could comment on that further when they're up here. And I believe for up to 3 years after the initial treatment. CAT scanning has been shown, both in the form of chest CAT scanning and abdominal CAT scanning, to be shown to be an effective tool as well, especially as it relates, as I alluded to a few moments ago, especially as it relates to the question of metastasis to the liver and potentially to the lung, although that's a little less clear in terms of the benefit. But in those instances, CAT scanning shows clear benefit, and as such, a CAT scan of the chest and abdomen are recommended every year for the first 3 years after diagnosis in patients who are candidates for attempted curative surgery. I often get asked about PET scans. This is not part of the routine armamentarium in looking for recurrence of tumors. It can potentially play a role in a selected group of patients, for example, patients who have an elevated CEA level, but for whom an investigation does not yield an obvious recurrence. But if the CEA is persistently abnormal, then potentially a PET scan might have some potential value in those patients to change treatment. Many of you are familiar with this tool here, which is the tool of the gastroenterologist, the colonoscope, and this is another potentially very valuable tool in looking for recurrence of tumors. Colonoscopy really is the only way to directly visualize the colon to identify tumors that are in the tube of the colon itself, rather than tumors that are outside the colon. The reason that colonoscopy has value is not just in the post-treatment period, but even in the peri-treatment period, if you will, because even at the time of the initial diagnosis of colon cancer, there is a not totally insignificant incidence of a second cancer being present at another location in the colon. And as such, it's important to have a good quality full colonoscopy performed at the time of diagnosis, if that's possible, in order to determine whether or not there might be a second cancer that might alter the treatment plan. Now, sometimes, some of you may be able to attest, sometimes you can't perform a full colonoscopy at the time of the initial diagnosis because you just can't get through with the colonoscope. And in those instances, it's recommended that a colonoscopy or some sort of study looking at the colon be performed perhaps 6 months or so after the initial treatment takes place, so that the rest of the colon can be cleared. Again, surveillance after the fact is recommended, and there is potential benefit for detecting not only recurrence of cancer, but also new tumors that may develop. And again, just a little statistics here for you. At least, up to 3% there are remote cancers in the first 5 years after surgery. And again, most of them come in the first couple of years. And up to 10% of tumors may develop at the prior surgical site as well. And that happens most commonly in rectal cancer. So again, postoperative endoscopy surveillance is an important tool as well. So the recommendations are, and many of you are probably already living testaments to this, the recommendations are after your initial diagnosis, repeat colonoscopy is initially recommended at 1 year after the initial clearance of the tumor. And then assuming that that is a normal colonoscopy, then 3 years after that. And assuming that is a normal colonoscopy, then you go back into sort of a pseudo-normal screening process of a colonoscopy every 5 years. What about family members? That's a question that often gets asked. And there obviously, there is a risk, a slightly increased risk, a somewhat increased risk of colon cancer in patients who have first-degree relatives who have colon cancer. If someone has had the diagnosis of colon cancer before the age of 60, then generally speaking, it's recommended that first-degree relatives get screened at an age 10 years younger than the age of the person who had the colon cancer to begin with. So, for example, if someone had colon cancer at age 55, then their first-degree relatives should be screened at age 45 for the first time. So that's important. That 10-year difference is part of the major recommendations. Or if two first-degree relatives have colon cancer regardless of the age, again, 10 years earlier than the youngest age, and then every 5 years thereafter. The majority of colon cancers are not hereditary. 95% of colon cancers do not have a genetic basis to them, but a small, significant percentage do. The so-called hereditary non-polyposis colon cancers, the Lynch family, as you may be familiar with. There are very strict criteria for what are Lynch-type patients. I won't go through them in detail right now, but be happy to discuss them later if anyone's interested. But in those patients who may have the strong family history that qualifies them as part of this so-called HNPCC, those patients need surveillance, or I should say screening, at a much higher rate. Colonoscopy every 1 to 2 years, starting at age 25, and then annually beginning at age 40. For those who have not had colon cancer, but who have merely had colon polyps, and I think that represents perhaps some of the people in this room, if you've had just polyps removed from your colon, depending on the size and depending on the nature of those polyps, the frequency at which repeat colonoscopy should be done is a very well described set of recommendations. If you've had a polyp that's greater than a centimeter, even one polyp that's greater than a centimeter, a repeat colonoscopy is recommended in 3 years' time. If you've had 3 or more polyps, even those that are not up to a centimeter, 3 years is the recommended follow-up. But if you've had 2 or fewer small polyps, then a 5-year recommendation for follow-up colonoscopy is recommended. At Penn, we do have a high-risk cancer genetics clinic, so if you have a strong family history and you haven't been evaluated, you can contact our division and an appointment can be set up to assess your particular risk. Your own doctor probably has already made those kinds of referrals for you if it's deemed appropriate for you. But I just wanted to make it clear that that is available to you, and that is part of the Abramson Cancer Center's offerings. And in general, screening colonoscopies at Penn are available. We do over 17,000 procedures a year at our various sites at Penn. And we're obviously very happy and willing to assist anyone who's interested in having their procedures done there or referring their families or friends. We obviously want to assist anyone in any way that we can. Our Penn Medicine at Radnor site is out here on the main line and has availability as well for anyone who may have the need. And obviously we're available all the time. So I'll stop there and we'll move on to the next talk. Thank you so much for your attention.
Thanks, David. My name is Josh Blyer. I'm one of the colorectal surgeons at Penn, and I'm going to talk to you a little bit about the latest advancements in the diagnosis and treatment of GI cancers as it relates to colon cancer. We'll try to move through the slides fairly quickly. As David said, we have a lot of speakers to get through. So we're going to talk briefly about staging of colon cancer, and then we're going to talk about the procedures that we do for colon cancer. We'll talk about laparoscopy for colon cancer, and then we'll talk a little bit about some new stuff that we can do with rectal cancers. To begin with, this is the organ we're talking about. Okay, this is the colon, and at the bottom there you see the rectum. And we're talking about tumors and polyps that we deal with surgically in this organ. Okay, all colon cancers originally start out as polyps, and as David said, that's why we do colonoscopies. There are 2 basic flavors of colon polyps. There's polyps on a stalk, or pedunculated polyps, and these are the ones that are fairly easy to get out with colonoscopy because we can get a little lasso around them and we can cut them off, and the stalk is usually a good margin, and the pathologist can tell us we've gotten everything and there's no cancer in it, or if there is, it tells us what to do. There are also flat polyps which grow in the wall of the colon, and these are much more difficult to deal with. These flat polyps also have a higher likelihood of development of cancer, and if there are premalignant cells in this, we usually treat these flat polyps as cancer, even if we don't find invasive cancer. And the reason for it is because the polyps are lined with the same lining as the colon, and that's where the cancers develop. And as you can see, with a polyp that's on a stalk, it takes much longer time for the cancer cells to grow down into the wall of the colon. And it's once the tumor that gets into the wall of the colon that it actually makes it a cancer that's a problem. Until the tumor cells get into the wall of the colon, they have no potential to spread elsewhere in the body. And simple removal of the tumor, whether that's with a colonoscope or whether that's with surgery, is 100% curative. Once the tumor has grown into the wall of the colon, the cells have access to the lymph glands and the potential to spread, although not all do. When these cancer cells grow in a flat polyp, they're already right there at the wall of the colon, which is one of the reasons why these flat polyps are a little bit more worrisome. So when we talk about cancers from a surgical standpoint, it's very important for us to talk about the primary tumor itself, because ultimately surgery is the best way to totally cure colon and rectal cancer. So early cancers, or what we call stage 0 or T0, are just tumors that haven't yet invaded into the wall. So they're not truly cancers. They're growing on the lining only. When we talk about a T1 tumor, it's starting to grow into the lining of the wall and now has potential access to those lymph glands and has a small but possible chance of spread. Stage 2 or T2 and T3 cancers just describe how deeply the tumor is growing through the wall. T2 is partially through the wall and T3 is all the way through the wall. And a T4 tumor is a tumor that's grown through the wall into another organ, into something next to it. And as you can see, once the tumors get into the wall, they have the possibility for getting into the lymph nodes and spreading elsewhere, like the liver and the lung, as Dr. Jaffe pointed out. And that doesn't mean that they're not surgically curable, it just means that it may be a little bit more difficult to do so. But ultimately, the way we stage colon cancers is based on the tumor itself, whether the nodes are involved, and whether or not there are spread. Stage 1 is an early tumor, a small one. Stage 2 is a slightly bigger but tumor that is not spread anywhere else. Stage 3 refers to any tumor that has spread into the lymph nodes, and stage 4 refers to tumors that have spread elsewhere beyond just the lymph nodes. And I'm sure you'll hear a little bit more about this. I deal with primarily the tumors that are stage 1 and 2 from a curative standpoint. All of these tumors probably require surgery, but ultimately stage 1 and stage 2 are curable by surgery alone. So what do we do for these tumors? Well, in very simple terms, wherever the tumor is, we remove that part of the colon or rectum, and then we try to reconnect the ends if possible, okay? And the way we do that is we divide all of the blood supply to the area of the colon that has the cancer. And when we do that, we take all of the lymph nodes with it. So the surgery itself takes the blood supply and the lymph nodes and the tumor. And that's how we can get our full diagnosis. That's what we call oncologic surgery, when we take the tumor, the lymph nodes, and all the blood supply, and then hopefully do a reconnection. And then the pathologist can tell us whether or not the lymph nodes are involved, and they can look at the tumor under the microscope, and that helps us determine if our oncology colleagues need help to really increase that chance of cure. Well, laparoscopy for colon cancer is simply another tool for us to do the same operation that we've been doing for a long time with bigger incisions. To cure and operate on colon cancer, we have to free up the colon from where it's attached internally so that it's mobile. So that when we cut out that piece, we then have freely mobile ends to reconnect. And laparoscopy is a way that we can do that with much smaller incisions. What we typically have is a small port where we put a camera in. There are other ports, and these are little incisions, 1 centimeter or less usually, and that we insert instruments through there. And using those instruments, we can do what we need to do internally. Whereas prior, we would have to make a big incision so that we could see everything on the inside. Occasionally, for hard to get to tumors or hard to mobilize things, we make a slightly bigger incision, big enough to actually get our hand in with a special instrument, which helps us assist with the surgery, but still leaves an incision that's quite small. Sometimes it's a transverse incision, or sometimes we do an up and down. And ultimately, these diagrams, these cartoons, illustrate how we free up and mobilize the colon from where it's stuck internally. And once we have fully mobilized this with looking at it through the camera and with our laparoscopic instruments, we then have a fully mobilized colon that we can pop out through a very small incision, do exactly what we did before, divide the blood supply, take all the lymph nodes, and then reconnect the cut ends. And when we're done, we're left with the very small incisions. And these are some pictures which can show you what it looks like. Quickly post-operatively, you can see these small port incisions and a very small extraction site. The skin can be stretched so we can get a large amount of tissue out through a very small incision. Here's another picture. It's about the size of a paper clip. Now, not every incision looks this way, but many of them do. This person had the whole colon and rectum removed and reconnected, and all she has is a scar from where her ileostomy was. And this is another incision we sometimes, in larger patients, will extract through a left lower quadrant incision as opposed to the middle. So laparoscopy has a lot of benefits. The cosmetic benefits are obvious. But what about bowel function? What are the other things? Bowel function is primarily what determines how long you're going to stay in the hospital, barring any complications. And we know, this is a list of a bunch of studies that have looked at this, and we know that laparoscopy in general decreases your hospital stay by about a day to a day and a half. It also can increase your quality of life. Less pain, because pain is often related to incision size. Not one-to-one always, but it is correlated. It is correlated. But also distress and other issues, overall quality of life, less pain medication needed, are all related to the use of laparoscopy. And again, we talked about hospital stay, and this sort of takes into account all of the factors, and in general, laparoscopic approaches to colon cancer decrease your hospital stay by about a day or two. Long-term benefits, so those are the short-term benefits, but is it the same? Are we giving up anything by doing this laparoscopically? Well, this is one of the most seminal studies that was done comparing laparoscopic to open surgery, because this had to be done before we could say that laparoscopy could be standard of care. This was done at the Mayo Clinic. And they looked at a bunch of factors, and what they found was when you did laparoscopic surgery for colon cancer, not surprisingly, the surgery time was longer, but the complications were no different. I'm sorry, that rectangle seems to have moved on me. Also, there was no difference in the complication rate, but narcotics use was less and length of stay was less. So less pain, again, and shorter stay in the hospital, and no difference in complications. And then looking at sort of the outcomes in terms of a cancer difference, there was none. Laparoscopic surgery was just as good of a cancer operation as open surgery. And this just is it makes no difference whether you have an early cancer or a late cancer. If you can be treated by laparoscopic surgery, there's no difference in the outcomes. Now, rectal cancer is a little bit more of a big deal, because when we have to remove part of the rectum, the potential complications of recovery for that are a little bit more. And those of you who've had rectal cancer surgery know what I'm saying, because the rectum is intimately involved with normal bowel function. You can lose a significant portion of your abdominal colon with little change in your bowel habits and little effect on your life. But when we have to start to remove the rectum, this can cause major changes in the way that you have your day-to-day life. And the lower the tumor is, the more the rectum that we have to remove, the higher the risk of complications. And even if we do that oncologically, sometimes you can still get recurrence. But what this is showing, that even stage 1 rectal cancer that's been cured after surgery, 90 to 92% of patients are totally cured. There is a small percentage of patients who can still have lymph nodes involved, as we mentioned, but for the vast majority of patients, radical surgery for rectal cancer can cure you. But we want to figure out how we can do it better, how we can potentially avoid the need for any of those changes. And since 90% of patients didn't have lymph nodes involved anyway, what about just removing the tumor itself without doing radical surgery? Now, it's true that this doesn't let us know what's going on in the lymph nodes, and it is a bit of an oncologic compromise. But when we're talking about the kinds of lifestyle changes that removal of the rectum can entail, that's not an insignificant question. So if we just do local excision, the pros are it's much less morbid. You don't have a stoma, you don't have the risk of sexual dysfunction, which can accompany rectal cancer surgery. It has a lower risk to your life. And as I said, there's a very high number of patients in early cancers who would never have had lymph nodes involved, and it wouldn't have made a difference whether or not you had oncologic surgery or not. And essentially, locally removing the tumor can give us information about the tumor, which may help then inform whether or not we should go ahead and do further surgery. Again, local excision doesn't let us know what's going on in the lymph nodes, and it's not an oncologic resection. And in theory, because of that small percentage of patients whose lymph nodes are involved, can affect recurrence rate and survival. But as you can see, local excision compared to radical excision is a much safer operation with a much lower risk of mortality and a much lower risk of surgical complications. So ideally, if you're a candidate for local excision, and we know that with our magic crystal ball, we would never do radical surgery on you. But the problem is we don't have that crystal ball. We need to try to do our best to figure out who is the perfect patient for local excision. So ideally, we're looking for small tumors. We're looking for tumors that are close to the anus, so reachable through the anus. We want early cancers. And also, we're looking for polyps that can't be removed by colonoscopy. Okay? This is what one of these typical types of early cancers looks like. And to remove it, we sort of use burning or laser technology or cautery, and we cut around the tumor. We go through the wall of the rectum completely into the fatty tissue around it, and then remove the tumor completely. And then we close up the hole. One of the things that we can do at Penn is something called TEM, or transanal endoscopic microsurgery. And this is a technique that was developed in the mid-'80s, but hasn't really been widely used. But it's a technique for removing tumors from the lower rectum that otherwise couldn't be removed by standard transanal techniques. It involves enhanced imaging we see in 3D. We use instrumentation similar to laparoscopic surgery. And it can allow us to remove tumors that are much higher in the rectum than we otherwise would be able to remove. And this is sort of what the setup looks like. And basically, it gives us a 3D view of those tumors, enhanced tools that we can't always use with a colonoscope, and gives us an ability to remove tumors that we would have otherwise had to do radical surgery. And why is this good? Well, when we compare TEM to standard transanal excision, we see that the recurrence rate of polyps is lower, which means that we're getting a better removal. We're getting better margins. And even for early rectal cancers, the recurrence rates are much lower. And this is just with removal alone. Recurrence rates of a transanal excision, because of our inability to see it as well, our inability to manipulate it quite as well, are about 14%. With TEM, it's a third of that. So those are just some of the things that are going on in rectal cancer and colon cancer, and I'd be happy to take any questions at the end of the session. Thank you.
Good morning. My name is Bruce Giantonio, and I'm going to be sharing the next talk with a colleague of mine, Nevin Adamjanov, who's sitting up here at the table with me. We're going to be talking about the medical management of colon and rectal cancers. I'm going to repeat some of the things that have already been said, but the things I'm going to repeat are things that I think are important for us to keep in mind as we talk about this disease. But first, keep in mind that colorectal cancer in the United States is the third most common cancer diagnosis in men and the third most common cancer diagnosis in women, but it's the second leading cause of cancer death in this country. So this disease is a big problem. There is good news. I had better news. So let me jump to this slide. So there is good news. Even though what I just said is troubling, this graph is a graph of survivorship for individuals that have colon cancer. And it takes information that dates back into the 70s and plots it into the 21st century. And what it tells us is that we have made substantial progress in improving how many people survive this disease. So there is good news. And one of the big pieces of good news is that we know that screening can prevent colon cancer deaths. We've already seen some of the data on this. We also know that more people with early disease can be cured of their disease through surgery and through improvements that we've made in the chemotherapy we give afterwards. We also know that people with advanced disease live longer. We may not be able to cure everybody, but those that have advanced disease live longer. And we're talking in terms of not just months, but with our modern chemotherapy, we're talking in terms of years. Therapy is always frightening and intimidating to us, but one of the other important advances that's been made is that the therapies that we're using are much better tolerated. And they're much better tolerated because the therapies are better and because we've gotten smarter in how to go about managing them. And then the other bit of good news, it's a double-edged, well, there's some bad news in here and I'm going to touch on later. There are many new drugs undergoing testing in clinical trials. So there's a lot of promise on the horizon. But there is bad news. The bad news, some of the bad news is that very few people undergo screening. And this is well established. Of all the people who are supposed to get colonoscopies, very small percentages of them actually get this done. Not all people with advanced disease benefit from treatment. We don't fully understand all the biology behind this disease so that our chemotherapy works in some people, but not in everybody. Side effects, even though we are better at managing them, still remain a problem for many people. And one of the problems that affects us all is that only 2 to 3% of adults with cancer in the United States go into a clinical trial. And that severely limits our ability to test these new drugs and get them out there and get them in use and start improving even further what we're seeing. We already saw a depiction of the colon. This is our colon again. I use this in large part to show that the cancers that occur in the colon occur throughout the colon. So this is down here's the rectum. This is the left side of the colon, what's called the transverse colon, and the right side of the colon. When we go for our screening, there's a variety of ways this can be done. And I'm going to maybe step out a little bit on a limb here. We heard about colonoscopy. There's another test called a proctosigmoidoscopy or a sigmoidoscopy. That test just looks to about here. To me, it makes sense that colonoscopy should be the test that we get when we're going through screening. To not do colonoscopy, to me, is like going for a skin exam for skin cancer and leaving our clothes on. It misses all the way over here. And there's a fair number of cancers that occur on that side. So I put my pitch in for colonoscopy. This drawing just is another way of looking at the staging system. And I want to just in grand terms, define the staging system, because we're going to look at some numbers that it's important to keep this in mind for. There's 3 things we look at when we stage a colon cancer. How much of the wall of the bowel has been invaded by the cancer, whether or not the lymph nodes are involved, and whether there's cancer somewhere else in the body. Those are the 3 things we use to stage the cancer. If it's not anywhere else, and it's not in the lymph nodes, it's stage 1 or 2. If it's in the lymph nodes, but not anywhere else, it's stage 3. And if it involves anywhere else, say the liver or the lungs, then it's stage 4. So first let's look at the screening information. Actually I can flip through this because Dr. Jaffe did a great job in presenting this. Where it's had a tremendous impact is that we're seeing cancers at a much earlier stage. At a much earlier stage where we can intervene in a way that's curative. This pie chart breaks down the data from 2009, and it looks at the stage people were at when they presented to us with their colon cancer. And you see 80% of these individuals were early stage. They had stage 1, 2, or 3. Only about 20% had stage 4, which is quite dramatic. That is a much different story than we saw in the 70s or even in the 80s. It was very unusual for us to see people with stage 1 or stage 2 colon cancers. We didn't have the good tool that the colonoscopy gives us to find these things. One of the messages I want to get across is that even though we see this as the 2nd leading cause of cancer death in the United States, it should be the lowest. It should be the lowest. And we have the tools to make it be the lowest. Colonoscopy is one of those major tools, and Dr. Jaffe touched on this study already. This was just reported in the New England Journal, and it showed us that if people undergo colonoscopy and have their polyps taken out, they're less likely to get colon cancer, and they're not going to die of colon cancer. That is an important thing. So colonoscopy does 2 things. It helps us screen, and it gives us an opportunity to do something that prevents colon cancer from happening. It allows us to take that polyp out and keep colon cancer from happening. As I mentioned, one of the other big advances is that we're able to cure more people with advanced disease, with early disease, because of improvements in our chemotherapy. And in addition, that people with advanced disease, even though we may not be able to offer them a cure, we're able to treat them in a way that allows them to live with their disease, and live with their disease in terms of years, not just a few months that happens when we don't do chemotherapy. This breaks down the treatment standards as we see them based upon stage. So individuals with stage 1 colon cancer, they get surgery and that's it. They don't need anything else. The likelihood of being cured after surgery is very high. And nobody's shown that chemotherapy given to these folks improves how well they do. In stage 3 disease, remember stage 3 individuals are the individuals that have a lymph node or more lymph nodes involved, but no disease anywhere else. There we know after after surgery, if we give them chemotherapy, a greater proportion of people are going to be cured of their cancer. Stage 2, it's an unanswered question. So these are individuals that have the tumor in the colon, but there's no lymph nodes involved and there's no cancer anywhere else. And we still aren't certain whether chemo helps these individuals or not. Many of us believe it does. But we base our treatment recommendations on the results of clinical trials, and right now, the definitive clinical trial for stage 2 cancer has not been done to show that chemo helps. But many of us believe it does, and many of us offer it to our stage 2 patients. And then in individuals that have the cancer that's gone elsewhere, it's either gone to the liver or to the lung, we know that there is still an opportunity to cure some of these individuals. The opportunity lies in combining chemotherapy with surgery. Using chemotherapy and surgery to try to reduce the volume of disease and go in and resect whatever we can see. And there are data that show that there's a proportion of people who will be cured if we take that maneuver. Now, the approach to treating this requires what we call a multidisciplinary team. I'm a medical oncologist. You know, I commonly get referred to as the drug pusher. We use surgical oncologists, we use radiation oncologists, but it's also important to realize that there's a lot of other people that need to contribute to the care of people living with colon rectal cancer. We have oncology nurse specialists, we have social workers and nutritionists that also provide vital roles in taking care of these individuals. I'm going to briefly touch on the chemotherapies that we use, and then Dr. Jamjanov is going to go through some of the strategies we employ to manage the side effects. Now, when we talk about chemotherapy, we have a tendency to lump all the drugs we use to treat cancer into this one big bucket called chemotherapy. But there's been a big advance in the last decade where we now talk about two buckets, chemotherapy and then what's called targeted therapy. Chemotherapy are the drugs that have been around for years. We know one of the things that happens in a cancer cell is that it just keeps dividing. It keeps making new cancer cells. And the way many chemotherapy works is it's like a monkey wrench. It just throws a monkey wrench into that process by which this rapid division happens. Targeted therapies are something that have been developed using much more smarter approaches. We studied what actually causes these normal cells to become cancerous, identify things that have gone wrong, and then come up with treatments that interfere with that. And there are two approaches that are used in the management of colorectal cancer that we'll touch on. The chemotherapy drugs we use, many of you are familiar with these. 5-FU. 5-FU has been around since 1957, and it still remains the backbone drug for the treatment of this disease. Capecitabine or Xeloda is an oral version of 5-FU. It's only been around maybe 10, 15 years. Oxaliplatin or Aloxatin and irinotecan or Camtazar are the two new kids on the block when it comes to chemotherapy for the management of this disease. They've been around for maybe about 10 years, 6 to 10 years at this point. Our targeted therapies fall into two big groups, and right now, unfortunately, the only studies that have been done to show that they work, the only places we've seen them work is in individuals that have metastatic disease. We've tried to test these drugs in the earlier stages, and they just don't seem to have the same impact. But they have a pronounced impact in people who have stage 4 cancer. There are two drugs that work at the same place. One is called cetuximab or Erbitux, and the other is called panitumumab or Vectibix. These names are tongue twisters, and we have trouble saying them. And I think they come up with these tongue twister names so that when they come up with a marketing name, the marketing name becomes easy to say, like Erbitux or Vectibix. Erbitux, just to refresh our memories, Erbitux is the drug that Martha Stewart went to jail over. And then bevacizumab works by a completely different mechanism. Bevacizumab also goes by the name of Avastin, and we'll touch on these in a moment. So there's three settings where we use treatment, chemotherapy or targeted therapy, or the combination of the two in colorectal cancer. One is following surgery to reduce the risk of having the cancer come back. And when we use it this way, we call it adjuvant therapy. A second way we use it is to use it before surgery to try to reduce the volume of tumor that we see so that we make the surgery easier. This is called neoadjuvant therapy. So the term is somewhat similar, has that word adjuvant, but neo meaning it's given before the surgery. And then we use it for individuals where we can't necessarily do surgery, but we want to try to control their disease or reduce it so that we correct the problems it may be causing so that people can live longer with their disease. So those are the three settings. As I mentioned earlier, our targeted therapies really are limited to that last setting. Our targeted therapies fall into two main groups, and one is very intriguing. This is it's an approach that's been, driving a lot of excitement for a few decades now, and it's called anti-angiogenesis. Angiogenesis is the birth of blood vessels. Angio, if anybody's had an angio catheter, it's the catheter for the blood vessel. Genesis meaning the birth of. So this is the birth of blood vessels. For a tumor to grow, it has to develop its own blood supply. It needs its own blood vessels to survive. And the tumor produces things that influences that controls that. Anti-angiogenesis therapy is therapy that's developed to try to stop that from happening, allowing these tumors to stop growing or to stop getting their own blood supply. This is just a cartoon I pulled from another slide set showing this. At the far end over here, here's a tumor that has its own blood supply. These red lines are the blood vessels. This is a small tumor that doesn't quite have its own blood supply yet, but it makes these proteins called VEGF. These proteins called VEGF go to the blood vessel and tell the blood vessel to start sending little shoots to the tumor, and eventually the tumor develops this very mature vascular system. And that's critical. It can't grow without this. It also creates a big problem because now the tumor has access to the blood vessels and it can shed cells into those blood vessels. So targeting angiogenesis has been an area that we've been very excited about, and we do have a drug in bevacizumab or Avastin that works in limiting this. The other approach we use is targeting something called the epidermal growth factor receptor. It's a bit of a long name, but the epidermal growth factor is a protein that's on the surface of many normal cells. It tells the cell to divide. So when we injure ourselves and that damaged area needs to repair the injury, this protein turns the cell on so that repair happens, and then it shuts off. In cancer, that protein gets turned on and it just stays on. And so the cell keeps being told, reproduce yourself, and it just keeps doing it. And we have two drugs that interfere with that, two drugs that bind to that protein and in effect shut that switch off. And those two drugs are Erbitux and Vectibix. Let me skip by that. So now I'm going to ask Dr. Damjanov to come up and talk through how we go about managing the side effects of these drugs. They all have side effects. One of the big hopes we had with the targeted therapies would be that they would be much better tolerated, and in fact, on the balance, they are, but they too have side effects.
Good morning, my name is Nevena Damjanov. I'm also a medical oncologist, which means that I also am a drug pusher or somebody who does chemotherapy. And the side effects of chemotherapy are what scares most people the most. And most people assume that if they're sick and if they need chemotherapy and if they have cancer, that they're going to be much, much sicker once they take chemotherapy. The first thing that most people assume that they're going to do is that they're going to lose their hair. Now, of course, some people lose their hair, but not everybody loses their hair. Some people come to me without hair already. So that's always a much more or less difficult discussion to have. So you may or may not experience common side effects. You may or may not experience the side effects of somebody else who had cancer. A lot of people will come and tell me, well, my neighbor down the street really got sick from chemotherapy and was unable to do what she needed to do. And then, of course, I would ask, Did this patient have colon cancer? Oh no, she had breast cancer. Or oh, she had leukemia. Or she went through a bone marrow transplant. So I'm going to tell you a little bit about the side effects and the management of medications that we use to treat colorectal cancer. It is really, really important that you and your physician, your medical oncologist specifically, talk about the side effects prior to initiating chemotherapy. Most of us are very upfront about it. And most of us will give you written information, frequently from Oncolink, and you can actually access them if we forgot, telling you about the likely side effects. Now, the fact that we tell you about the likely side effects, once again, does not mean that you will get the side effects. And sometimes people are pleasantly surprised about how well they're able to tolerate chemotherapy. So please don't be scared of chemotherapy. We're trying to do more good than harm. Many patients are reluctant to report side effects. We assume that if you don't tell us, it's not happening. And of course, sometimes when we come to see you in the hospital because you were admitted because of side effects from chemotherapy, we will figure out what you forgot to tell us. But it would really, really be helpful if you tell us ahead of time, before you get so sick that you need to be admitted, that you're having troubles. Frequently, we can even take care of some of the side effects over the telephone, or tell you, well, you know, this is not likely to be related to chemotherapy. It may be due to something else, so maybe you need to talk to one of your other doctors. Patients are frequently reluctant to tell the doctor that they're having chemotherapy because they're afraid that the doctor will reduce the dose of the chemotherapy. And if we reduce the dose of the chemotherapy, perhaps the chemotherapy will not be as effective. Well, the chemotherapy we usually give at what's called the maximal tolerated dose. In other words, what a lot of people were able to tolerate beforehand. However, even in the clinical trials that showed that the chemotherapy is active, a lot of people had to have their dose reduced. So we wouldn't be recommending a dose reduction if we did not believe that the likelihood of benefit exceeds the likelihood of harm. And this is the part of where the hospital, we figure things out when the patient ends up in the hospital. Failure to adjust doses may lead to life-threatening toxicities and treatment delays and a reduced quality of life. We hope to keep people active and able to do what they need to do as much as possible. So tell us if you're having a problem. Tell us if we're not doing a good job of controlling your side effects. Frequently, we have Plan B. We have something else that we can do to help you deal with the side effects. It is important to report it to your doctor. Please let us know. We're nice people. For the most part, we want to help people, right? Tell us. People are scared of nausea and vomiting, and now, which is different than 20, 30 years ago, we're pretty good at controlling nausea and vomiting. And we will frequently give you medications ahead of time to prevent nausea and vomiting. Frequently, we will prescribe medications to your pharmacy and ask you to fill those medications ahead of time. For the most part, once again, especially if you're getting intravenous chemotherapy in the office, we will give you the antiemetics, the medication to prevent nausea and vomiting in the office before your chemotherapy. As I joke with my patients, we don't trust you to do things correctly at home. So we will give you the medications ahead of time, prevent nausea and vomiting when you're in the office, and then you will have medications at home to treat any symptoms you might have when you're at home. Zofran, Kytril, Anzamet, Compazine, Reglan, and there are lots of them out there that can help treat nausea and vomiting. So usually we will prescribe maybe 2 medications, for example, Zofran or ondansetron and dexamethasone or decadron. Say, try these, and we'll give you a schedule when to take them. And if it doesn't work, call us. We can add something else. We can change things around, make life better. A lot of people find that when they're on chemotherapy, food doesn't taste right, or food doesn't smell right, or chocolate cake that used to be so delicious just doesn't cut it anymore. What makes you sick? Don't do it. So if fried fatty foods turn your stomach, please don't eat fried fatty foods. I mean, it sounds counterintuitive, I mean, it sounds intuitive, but a lot of people say, well, you know, I need to keep my weight up. so I need to eat fatty food, or I need to eat a macrobiotic diet because somebody said it's good. But if the macrobiotic diet makes you feel worse, then it's not the right thing to do for you. We try to personalize medicine, we try to personalize the way we treat people, but also you need to personalize what you do at home to maximize the benefit that you're getting from the treatment. So use common sense. If it makes you sick, don't do it. Smaller meals are frequently prescribed by the dietitians. As you know, here we try very hard to have a multidisciplinary approach to the way we do things. So when the dietitian comes, one of the first things they will tell you is, don't overstuff your stomach because it may make you queasy. Eat small, frequent meals, graze, which I understand is a good thing for most of us. Eating small, frequent meals during the day prevents a lot of things, including obesity. If you have diarrhea, and unfortunately a lot of our chemotherapeutic drugs do cause diarrhea, we will tell you, go to the pharmacy and get Imodium. Imodium is over the counter, and it works very, very well. On the back of the box, usually it says, don't take more than 4 pills a day unless you discuss it with your doctor. Well, we're your doctors, and frequently we will tell you, take more. Unfortunately, people forget that, and they read the box, and they get really, really upset because they need more than 4 pills a day. So, once again, listen to your doctor, call the doctor. Frequently, we can help you over the telephone without getting too much trouble. Diphenoxylate with atropine, otherwise known as Lamodal, is a prescription medication. It's, once again, also very effective for diarrhea. And in patients who have chemotherapy-induced diarrhea that is so difficult to control that they end up hospitalized, so it's just pouring out of them, there's a medication called sandostatin or octreotide. It's given parenterally, meaning not through the mouth. It's an injection that can be given either 3 times a day or once a month, depending on how severe the diarrhea is. Oxaliplatin. Oxaliplatin is a very good medication that works very, very well with 5-FU and leucovorin chemotherapy. So oxaliplatin is a chemotherapy that adds efficacy to 5-FU, as Dr. Giantonio said. 5-FU is the backbone of treatment for colon cancer. Our favorite treatment with oxaliplatin is called FOLFOX chemotherapy. Many of you may have heard of it. Sometimes we combine it with Avastin or bevacizumab. Sometimes we don't. It really depends on what's the right thing for you. Oxaliplatin, as you can tell from the name, the platin is platinum. It's the same stuff that some people have in their rings. So platinum is a heavy metal. It gets into the body and stays there. And it can cause significant neuropathy, meaning nerve damage. It can cause permanent nerve damage, like diabetes can cause nerve damage. And that can be permanent. And it can cause what we call cold dysesthesias. We always have big names for very simple things that we observe, because that makes us sound very smart. So cold dysesthesia means it hurts when you do something in the cold. So if you touch something cold for 3 to 5 days after getting oxaliplatin chemotherapy, you may feel like an electric shock is going off your arm. If you drink cold water, you may feel as if you're drinking broken glass. If you take a deep breath of cold air, it may feel as if your throat is closing off. All those things are very unpleasant, but they're not medically dangerous, which sounds strange, but honestly it isn't. So we tell you before you start oxaliplatin, if you'd experience any of these side effects, please don't do what just made this happen. So don't drink cold drinks, drink them at room temperature. If you're going to take the frozen peas out of the freezer, use gloves. This is not the right time to be doing exercises in the cold and taking deep breaths of cold air, because you may feel unwell after you do that. And the burning or prickling feeling without stimulus, that's the neuropathy. That's people with diabetes get it. People with other chemotherapies may experience it. People who have had Taxol, paclitaxel, if they've had other kinds of cancers before. And frequently, what we will do is when we will ask you, are you having numbness and tingling? There's no physical test that we can figure out if you're having it. If you don't complain about it, we don't know about it. If you complain about it, if you tell us, yes, I'm having numbness and tingling and it's not going away by the next treatment, We don't want to make it worse, so we frequently reduce the dose. Some people give calcium and magnesium infusions, which can make the infusion time much, much, much longer. But there are different ways of dealing with it. We acknowledge it, and we try to prevent it from becoming permanent. But we can't tell unless you complain to us about it. Stomatitis and mucositis, also big words, which means sores in the mouth. It hurts to swallow, it hurts to eat. We'd like for you to continue to eat and drink because people who eat and drink tend to remain healthier. So the nurses will tell you use baking soda as a mouthwash. There's magic mouthwash, which is a medication that the pharmacist will mix up that contains Maalox, a numbing medicine like xylocaine, and Benadryl. That's it. So it's otherwise known as BMX or magic mouthwash, and what it does is it numbs up the mouth, so it allows you to eat and drink so you don't get in trouble later down the line. Hand-foot syndrome. We also have a cool name for that. Palmar plantar erythrodysesthesias, or PPE. Hand-foot syndrome is most common in patients who are taking capecitabine or Xeloda, XELODA. It's a medication that, as Dr. Giantonio told you, is transformed into 5-fluorouracil in the body. And people who are on high doses of that can get significant painful red feet and hands. And we try to prevent that and treat it if it does happen. We want to keep hands and feet clean and moist, use mild soaps, no rubbing, use alcohol-free emollients, avoid topical anesthetics so that you can continue to feel, and immerse hands and feet in cool water several times daily. Frequently putting it into hot water will make things worse. Bevacizumab or Avastin adds efficacy to our standard treatment, our standard chemotherapies. However, everything comes at a price. Bevacizumab or Avastin may increase your blood pressure significantly. I personally like to work with the primary care doctors so that we all remain involved in patient care. So if somebody has very difficult to treat blood pressure problems, I will send them back. Other doctors will address the blood pressure problem themselves. Bevacizumab affects blood vessels, so it can increase the risk of bleeding. It can cause delayed wound healing because the blood vessels don't help the body heal well. You can get blood clots. I know it's strange. You can have bleeding and clotting, and sometimes it happens in the same person, and it can be very difficult to treat. It is very rare, but it's definite. Something that we need to watch out for is perforation. You can get a hole in your gastrointestinal system. It can happen at the site of surgery where you had the cancer. It can happen somewhere else. So if you are on bevacizumab or Avastin and you tell your doctor that you're having increasing abdominal pain, we tend to get very, very excited. And proteinuria, dumping protein into urine, can be a problem in patients who are on bevacizumab. It's also seen in people who have diabetes. Cetuximab or Erbitux, panitumumab or Vectibix, they're anti-epidermal growth factor receptor. This cetuximab, because it's a protein that has both mouse and human components, can cause allergic type reactions. It tends to happen in the chair while you're getting treatment. Both of them can get an acne-like rash. It's not true acne, it may look like acne, and you may say, how can I possibly have acne when I didn't have it as a teenager? It's not true acne, it's an inflammatory reaction. And we tend to prescribe anti-inflammatory agents. We'll give you hydrocortisone cream, emollients, sometimes antibiotics to prevent it worsening. Low magnesium and calcium, that's why we do all those blood tests when you go to the doctor. And very, very rarely some interstitial lung disease, which is difficulty breathing. And we try to prevent things. So we'll tell people, stay out of the sun. That's both for 5-fluorouracil as well as for cetuximab and panitumumab. You're more likely to get a sunburn, a severe, severe sunburn. So always wear SPF 15 or greater. Use mild soaps because remember, even though it looks like acne, this is no time for Clearasil. Water-based makeup so that you don't clog your pores. Topical or oral antibiotics, frequently doxycycline. Antihistamines to prevent the itching. Cool compresses because of the redness can be quite a lot of discomfort. And Things that will keep the moisture in the skin: petroleum jelly, silver sulfadiazine ointment for lesions that are very deep. Sexual side effects, we don't talk about this a lot. Why? Because we're all uncomfortable about talking about sexual side effects. So if your doctor doesn't talk about it, say, I'm having an issue. We can't guess. We want to make sure that we improve your quality of life as much as possible, but we understand that surgery, chemotherapy, the side effects of both of them can cause emotional, physical stress that can decrease the libido, so you may not be as interested in having intercourse. The body image may be altered, especially if you have a colostomy. What I found is in most people, the partners don't care as much as the person who is worried about it. There are pouch covers for ostomies. They come in lots of lovely colors. And it really can be an almost acceptable way of dealing with a somewhat difficult issue. Erectile dysfunction, Viagra, Cialis, Levitra, there are lots of medications out there to try to help. And if it doesn't work because the nerves are damaged, there are mechanical ways of helping with that. Vaginal dryness. This is very common in women who've had breast cancer, but also women who've had radiation or just postmenopausal. If the gynecologist is reluctant to prescribe estrogen creams, there are over-the-counter medications located right next to the condoms that can be very helpful. And fertility issues, remember, chemotherapy kills rapidly dividing cells, including the ones that are found in the ovaries and in the sperm. So fertility issues can be a significant issue, especially as women get older. Fear of recurrence, that is something that is very common in everyone. We want to make sure that you're informed. Sometimes we cannot tell you there's no way this is going to come back. We can just tell you, no, if you do this, the likelihood of it coming back is lower. If you're worried, let us be worried as well. Realize that it's a long journey. You'll have good days, you'll have bad days. It's healthy to express negative emotions. Do not let anxiety and fear prevent you from seeking medical care. This is what we think is the current standard of care for follow-up. In other words, usually because the highest risk is in the first 2 years, we tend to see you more frequently in the first 2 years, then less frequently in the next 3 years, and at 5 years we tend to really free up the reins, but frequently we'll see you on a regular basis even after that. So there are many new therapies in clinical trials, as Dr. Giantonio said. Clinical trials are scary to some people because they don't want to be experimented upon, but remember, all of our treatments came through clinical trials. So people who were, shall we say, brave enough to participate in clinical trials were able to get the benefit of some new medications before the rest of the population. So I strongly encourage people to participate in clinical trials if they're appropriate and if there's one that's the right fit for you. There are lots of research that is ongoing for better cancer treatment, new chemotherapies, new targeted treatments, new screening tools you can see. And there are 2 new drugs that are hopefully going to be on the market fairly soon. One is aflibercept. It is similar to bevacizumab or Avastin, but it's called a VEGF trap. And regorafenib, the fact that it's a NIB tells us that it's a tyrosine kinase inhibitor, and it tells that it's a targeted therapy against some of the proteins that are on the inside of the cell. Apparently, Dr. Giantonio has cancer jeopardy, colon cancer jeopardy. So the answer is 54% in Delaware and 77% in Nebraska. Any idea?
How many people get colonoscopy?
Really? What is the percentage of Americans over the age of 50 or older who have not had a sigmoidoscopy or colonoscopy during the past 5 years? So way, way too many. And if our goal is to treat colon cancer, if our goal is to get rid of colon cancer, prevent it, and granted, no screening tool is 100% effective, but it's the best that we have. Mammograms, colonoscopies, pap smears, all of those are excellent tests to discover the cancer early, get rid of it before it starts causing problems, before it gives you symptoms. Early colon cancer does not have symptoms frequently. Get rid of it before it gives you symptoms, before it causes problems, before it can kill you. Thank you very much for your attention.
Hi, Mike Watson, Interventional Radiology. I appreciate the chance to speak with cancer survivors, cancer patients, and their families, because they're some of the select few who I don't have to explain what interventional radiology is. But if you don't know, I'm the person who comes to the colorectal breakout session and doesn't show a picture of the colon. So kind of where we can help with our therapies in interventional radiology is when we get to the point that was touched upon briefly by Dr. Jaffe and the others, where your colon cancer has now metastasized and it involves the liver. And we have what we call liver-directed therapies. And there's been a number of references that the goal now, especially now and not so much 20 years ago, is to remove the metastatic lesion in the liver and actually be able to resect it. And that is the standard of care, is to surgically remove the lesion. But there are some cases where there's too many lesions in the liver, they're too close to the major blood vessels, or the liver can't really handle having a chunk taken out of it. And that's kind of where we come in. So we're looking at liver-dominant disease. So maybe the colon cancer primary lesion is gone, and the kind of majority or all of the kind of cancer that remains is in the liver. So we're not necessarily looking for cure, though we do achieve it, and I'll talk about the methods we use. We do achieve cure, not infrequently, but that's not our goal. Our goal is to not allow the cancer that has come from your colon and settled in the liver, we don't want that to be the cause of mortality. So as long as we can keep beating back the cancer in the liver and not allow that to cause mortality, then we're doing our job. This is kind of a simplistic, very simplistic treatment algorithm for metastatic diseases from colorectal cancer. And if you have metastatic lesions to the liver, resectability on the left is kind of the goal, usually along with chemotherapy. Liver-dominant unresectable disease, have some lab values that show that we can intervene, and this is kind of where we can come in with ablation or embolization along with systemic chemotherapy. And then if it's not liver-dominant disease or there's contraindication to one of our treatments, systemic chemotherapy is generally the way we go, but this is the best arrow I could find. There's a lot of interplay between these categories, and there's not so much of just, kind of, there's movement in between categories. There's ways to integrate all of these things for the best results. So the first one to talk about is ablation. So ablation is actually treating the tumor in the liver itself percutaneously or through the skin, and treating it with thermal energy, which is either heating, which is kind of the most common way it's done now, with radio frequency ablation or microwave ablation, or alternatively with cooling and actually freezing the tumor until it's just an ice ball. And either way, the thermal energy will effectively kill the tumor. So this is kind of the radio frequency ablation probe, and you can see how it actually sticks into the right side of the patient in this case, and actually opens up those kind of prongs within the tumor in the liver. And we're monitoring this with either ultrasound or CAT scan to know exactly where it is. In this case, this is a same-day outpatient procedure where someone will come in the morning, have an IV put in for sedation, and then either ultrasound or CAT scan we will use to guide this probe and hook it up to a generator, and anywhere between, with a lot of sedation for your benefit, between 15 and 40 minutes, and our treatment is done. So we have to kind of choose who can get this treatment. We talked about unresectable disease because all the data still shows that surgically removing these lesions is the best, but we think that based on some of the data we have that we can approach those benefits with ablation. So if you have less than 3 lesions, less than 3 centimeters, good candidate. We're kind of stretching ourselves if you get into more than 4 lesions or 5 centimeters, and above that, we're kind of at our limits with ablation, but You know, it's not something that is out of the question if everything else is okay. And that's a discussion that, you know, before we do this, you'd be referred to us from one of your oncologists, and then we would have this discussion in an office setting beforehand. So how do we know if we can do this? Well, can we see it? We're you know, interventional radiologists, we're radiologists. We have to see what we're looking at. So we can use ultrasound, CAT scan. MRI is a little bit difficult because a lot of these things are made of metal, and it makes a lot of people nervous to bring metal near an MRI. So you know, it can be done. We don't do it often. And then how is your blood clotting? Somewhat normal. We don't want to cause any bleeding. That would be the risk of the procedure. And so as long as there's some minimal criteria met, we can usually go ahead. The other issue is we're using super heat or super cold, and we don't want things that are very close to get damaged. And there's a list of things there that can be kind of collateral damage that we're very careful to watch out for. You don't see blood vessels on there. Well, you do see blood vessels on there. But sometimes blood vessels can help us to actually help carry away some of the heat and allows us to actually do a better treatment on the lesion. So again, here are different devices. This one up here opens like an umbrella. These ones here are straight and kind of just cause a spherical thermal injury around them. And this guy is a much more flexible kind of probe that we can get in crazy little areas. So this is the kind of futuristic, conceptual, artistic rendering of what RF ablation looks like. But this is what we actually see. If we're doing this ultrasound, and we actually do prefer often to this ultrasound, we can actually change it just like you're looking at a baby with an ultrasound. We can look at the liver, and as we kind of move the needle through, we can see exactly where it's going. There's some steerability where we can get it around places that we otherwise wouldn't get to. We can go around ribs and kind of get it to where we need to go right into the tumor. And then as we do the ablation, the problem with ultrasound is as the local environment of that tumor changes, the images change, and we have a very difficult time seeing when we're done. So we'll do say, well, we're going to do 10 minutes at whatever amount of power or whatever temperature, and then have that, and then we have to check a month later and see how we did. As far as CAT scan, this is the other way we can do it. This is actually kind of easier for visualization. But it's limited in a lot of things. We can't see what we're doing real time. We have to put the probe in and then scan and then wait and then scan. And then we can kind of assess our progress a little bit more easily, but it all depends on factors of location and inherent properties of the tumor of which we can do. And I mentioned cryoablation or encasing the lesion with an ice ball. The numbers as far as effectiveness and survivability are not really well established with those, so we're still working on those. Now we can talk about the intra-arterial therapies we use, and these are basically I don't know if any of you have had a heart catheterization before. A lot of people have, but we kind of do the same thing. We make a needle stick in the artery in your upper leg, which we do everything through a tube that's actually less than 2 millimeters in diameter, so a couple hundredths of an inch, with some local numbing medication. And everything I'm going to show from here on out is done through that little plastic tube. So what you see here is a tumor in the liver, and the blue blood vessel is the portal vein where your normal liver gets about 75% of its blood from this portal vein. The red one is the hepatic artery. Your normal liver only gets about 25% of blood from the artery. So the liver is unique in that it has two different blood sources. The really advantageous stuff for us is that when, as it was talked about before with this angiogenesis, when a tumor needs blood, it recruits arteries. So most people, if they have relatively normal liver function, can pretty much live without the artery to their liver and just live on the portal blood supply, whereas the tumor needs the artery to survive. So this was kind of figured out in 1950s, that's how the tumors worked. So in the 1960s, people started giving intra-arterial chemotherapy instead of intravenous chemotherapy. And then there were a couple studies that showed that this can be effective, but the delivery method kind of needed to be figured out. So what we do quite often is what we call chemoembolization. Chemo meaning we're giving chemotherapeutic drugs. Embolization means we're stopping the blood flow to the tumor. So we have to do a combination of things, and we want to embolize the blood supply or stop blood flow to the tumor. And there's a few different ways we can do that, and we want to deliver chemotherapy. Delivering this chemotherapy, we can do this in doses that are much higher than you can get intravenous because of all the side effects that were spoken about. Since we're delivering it directly to the tumor, directly to the liver, these side effects are generally much less prevalent and much better tolerated. So we can give one chemotherapy drug. The CAM is what we do at Penn, and that's cisplatin, adriamycin, and mitomycin. But there's a lot of different people who use different drug regimens, and then so what they'll do is they'll dissolve the drugs in this thick oil, and the oil actually makes its way into the tumor vessels, and then they put these little almost microscopic beads behind them. The beads block in the chemotherapy, stops any more blood from getting in. And that's kind of what this little cartoon shows. The healthy pinkish tumor up here. Now we have our little tube in there, and we're giving the chemotherapy, which magically turns the tumor yellow, which is really what happens. And then we give the little particles that block the blood supply to the tumor after we give the chemotherapy. And generally we follow up with another MRI or so in a month, and we like to see the tumors have shrunk. We can see how much of the tumor is still alive, if any. Oftentimes there still is, but we will shrink it back. And let me go back here. The way we like to think about it is that a tumor has a certain kind of growing time or doubling time. And if you have a tumor that's a couple centimeters in your liver, it's been there for a certain number of months or years. And if we can kind of beat it back to a smaller size, it needs to take that much time to grow into the size again. So it's kind of a constant battle sometimes to just continue to make sure that the tumor isn't overcoming too much of your liver to function. So this is kind of what we see. This is our tiny little catheter or a few millimeter tube, which is coming up from the leg, going into one of the blood vessels that go to your liver. And then your liver is going to be hanging out over here, so we can become a little bit more selective with where we put our catheter. It's actually about here. And we can start seeing the blood vessels go to your liver, and what we generally see ends up looking like this. So this is the tumor, and it's getting a lot more blood from the artery than your liver is, and it makes itself quite evident. So once we see that, we can give the chemotherapy medications. We can give the embolic medications to block the blood vessel, and then we can come out, and then in this procedure, you stay with us for a night. The patient stays with us for a night because it does tend to cause frequently nausea, vomiting, abdominal pain, which we monitor very closely and give antiemetic medications and pain medications. But it's a next day kind of 23-hour admit and then follow up in a month. The next and final thing I'm just going to briefly touch upon is radioembolization, and that's actually giving radioactive particles, radioactive beads, which cause very, very localized radiation effects to the tumor and not to the rest of the body. So the actual isotope is yttrium-90, and these spheres, these beads, are very, very tiny. 25 to 30 microns, which is, I'll kind of show you a little diagram of that in a second. There are two different kinds, spheres, which is the ones we use for colorectal cancer, and then we have to do calculations beforehand as far as how much liver is going to be treated. We have to do an angiogram beforehand to take pictures of the artery to make sure that we know what the mapping kind of looks like. And then the other thing is, since we're going to be giving these little beads that emit radiation for a number of months, we have to do a little test injection of a radio tracer, which will act as a marker but not give any therapeutic radiation to make sure that these things aren't going to end up in your lungs or your stomach. So it's kind of a two-step procedure. This is what I want to show you here. When it says TACE, that's transarterial chemoembolization, those big green things are the things we give to block off the blood vessels to the tumor. When we're using the radio embolization, or the tiny little Y90 spheres, they're this big, and what they actually do is they actually make their way inside the tumor. So when they're giving off the radiation, it goes just into the tumor, and on the order of millimeters outside. So they're very, very small little particles. So they do a quick calculation based on CAT scan, how much liver needs to be treated, how much of the radiation dose you need. Kind of looks like this. And then our first planning procedure, we give you the marker, like I said, and we like to see the liver like this light up, and that means that whatever medication, whatever radiation we're going to give you is going to stay in the liver. If we see this, that means that if we gave you radiation, here's the liver, these are the lungs, and it would go to your lungs and cause, serious permanent respiratory problems. So that means you would not be a candidate for the procedure, and you'd have to go back to one of the others. Again, this is a same-day thing. Go home. It's actually go home the same day. This is much better tolerated symptomatically than the chemoembolization because the actual treatment occurs over the next 6 months rather than over that night. So it's a lot better tolerated as far as pain, and people don't really complain of having any pain or discomfort. And what we see very often is we'll sit down in the office and have a conversation and say, you have X number of tumors in your liver and we can treat them. We can treat them with a medication that will basically kill them over the next few days and you'll be in agony. Some people aren't in agony, but some people are. Or we can treat them slowly over the next 6 months and you won't have any discomfort at all. The first time people say, I want the one that kills them now. And then if they have to come back again, they say, let's not do that again. Let's do the slower one that I'm not going to feel. But this is kind of a little picture of how these things are actually delivered. Like I said, here's the tube that's on the order of millimeters that's going into the upper leg. Here's the feet down here. And then there's this contraption that's looking like it was made in somebody's garage with all these tubes and wires coming through. And there's a big lead pot there where the radioactivity is. And we just kind of flush it in with some fluid, which is drawn here. So basically, there are a few things that we can offer when the cancer is involving the liver and is centralized in the liver. And so these ablative therapies, there's a lot of data that show if it's less than 3 centimeters in size, we're aiming for a cure. If it's above that, we would like to see a cure. We don't necessarily expect it, but we can certainly, like I said, beat things back. And then the intraarterial therapy is for control. Again, not really looking for cure, but we have people that we've been seeing for years, and maybe they do 2 procedures to start, and then nothing for 9 months, 10 months, 12 months, maybe 15 months. Something pops up a little bit, do it again, and you can go on for years like this. And then, of course, we can't do anything without systemic chemotherapy often, without referrals and interdisciplinary discussions with the other oncologists. And, we just, once we can control the liver, kind of what happens is based on what happens with the rest of the disease and the rest of the body. That's all I got.
Good morning. I'm Edgar Ben-Joseph. I'm a radiation oncologist here, and I'm going to talk about radiotherapy for rectal cancer. And let's see if I can control this. One of the advantages of speaking last is that a lot of the things that I thought that I might need to explain have already been discussed. So this could be fairly quick. I also realize that I'm the only thing standing between you and lunch, so I'll try and be brief. You've heard that small cancers of the rectum can be treated very well with surgery, sometimes surgery and chemotherapy, but the more advanced one, the ones that go through the wall of the rectum or the ones that have lymph nodes require all 3 modalities. And the use of all 3 modalities, chemotherapy, radiotherapy, and surgery, has become the standard of care. It's based on this landmark trial, the German trial, and we give chemo and radiotherapy before surgery. And doing that controls the majority of these cancers locally. Radiotherapy is a local modality. That is, we are trying to supplement and prevent some of the recurrences of the cancer right in the rectal area. And if you use all those 3 modalities, the chance that a cancer would come back locally in the rectal area is quite low. It's of the order of 5 or 7%. So there were a number of things that people have tried over the last few years to try and improve on that. It's hard to improve on such a high local control rate of the order of 95%. Nevertheless, one question that was aggressively investigated was, if you use more intense chemotherapy along with the radiotherapy, are the results any better? And that's the first item there on the research agenda that we'll talk about this morning. The other main thrust of research is how to reduce the side effects of radiotherapy. So the local control is pretty high. Can we do something to improve side effect profile? Can we do something to improve the quality of life of patients as they go through this kind of treatment? And then finally, and touching upon the second point is, are there any group of patients who currently we are recommending sort of routinely the use of all these three modalities that can be spared radiotherapy? Maybe we can identify a group that can be treated without radiotherapy. So you could think about it as good news or bad news, but there are now 4 studies that are enlisted there that suggest that there's no benefit from adding very aggressive chemotherapy such as FOLFOX or CAPOX to radiotherapy when you're treating together before surgery. If you do that, it only adds to the toxicity of therapy, does not add to the control of cancer. So we are back in that sense to the very basic medication 5-FU or its oral prodrug capecitabine combined with radiation as the preoperative standard care. It does have less side effects and it's quite effective. How can we reduce side effects of radiotherapy for rectal cancer? So there's lots and lots of new things, new technologies that have evolved over the past 10 years or so that are gradually being introduced into the treatment of rectal cancer and being tested in rectal cancer. These technologies that I'm going to just briefly touch on are intensity modulated radiotherapy, IMRT, proton therapy, which is heavy particles. In general, radiation is mostly X-rays. These are very, very high X-rays that you throw at the tumor at high velocities, very high energy. And as these X-rays go through the tumor, they can kill any cancer cells within that. Protons are very heavy atomic particles, and you do exactly the same thing with these protons. You throw them at the tumor, and as they go through the tumor, these interactions of these heavy energetic particles with the cancer can kill the cancer cells. It's another way, and maybe a little bit more effective way, in particular in sparing side effects of treating different cancers. And data is just now starting to emerge that maybe it is a good idea to use it in rectal cancer. The other question is, are we treating the right volumes? When I'm talking about volumes, I'm talking about the parts of the pelvis that we are treating today. Can we get by with treating less of what we treat today? We'll talk a bit about that. And finally, as I said, can we find people who do not need radiotherapy? The best radiotherapy is no radiotherapy at all. That would have the least side effects. So here's a study that was just published in an abstract form not too long ago. It's the RTOG0822, and it was a phase 2 study that was designed to look at the side effect profile of intensity modulated radiotherapy. And what IMRT is, it's a technology that instead of shining 2 or 3 or 4 big beams of radiotherapy at the cancer, using hundreds and hundreds of very small beamlets that each one is modulated, the fluence through that beamlet is modulated independently. And what that can do, it can actually give us very, very focused radiotherapy. It could treat the tumor to much higher doses, and it could really reduce quite dramatically the dose to the structures around the cancer, those organs that we call them in the radiotherapy jargon, the organs at risk. Those are the other organs in the pelvis that are susceptible to the side effects, and these would be the skin or the perineal area, the bladder, it could be the uterus and the vagina, the genitalia, the gastrointestinal tract, the small intestine. All could be damaged by radiotherapy. And the preliminary data suggests that, yes, this is slightly better. If you look on the very right-hand side column there, I'm not sure exactly how this works, but this, yeah. The grade 2 and above toxicity, if you look at the sort of percentage of patients who had toxicity, has been reduced slightly from 58% to 51%, but this is not highly statistically significant. So There's still some work that needs to go into that to see if this is enough of a reduction that justifies this particular technology. And we're waiting for more studies. The good news with using this very focal radiotherapy is that the control rates do not seem to be any worse than they have been before. And one of the ways that people have looked in this study to see if the impact of this kind of radiotherapy on the cancer is good enough is to look at how many patients did not have any cancer in the specimen once it was removed surgically after this radiotherapy. And the number was 15% of these patients did not have any cancer left in the pelvis after this kind of treatment. It's very similar to what it has been previously. So the good thing is that we feel a little bit more confident that we're not compromising any outcomes. It's not quite clear if it's helpful yet. So we talked about protons, and protons is a very expensive endeavor on the part of the institution. It's a multi-million-dollar machine of the order of $250 million that a hospital needs to invest in equipment. Luckily, one is available at Penn. And this is just a study that was published last month in radiotherapy and oncology. And what you see there really is just very briefly is this is the area that receives high-dose radiotherapy. Anything in red is an area that receives very high radiotherapy. This is protons. This is intensity modulated radiotherapy. These are more standard technologies. And you can see that the areas of the pelvis that are treated with standard techniques is much higher than it is when you're using protons or when you're using intensity modulated radiotherapy. And in particular, if you look at the areas in red, you could see that that it's much smaller when you're using sophisticated technologies. What that means is that we could spare, for instance, the front structures. This is a slice through a patient. The buttocks are up there. The front is down here. So in this particular case, you can see how we could spare very nicely. The region of the high dose only covers the targets, the rectum and the structures around the rectum, but for instance spares very, very nicely, much more than here or there, the front parts, in this case the bladder or the femoral heads, which sometimes cause troubles to patients. So it seems like that at least on the face of it, these technologies could really reduce the dose that is distributed to these structures and potentially be helpful. How about treating less? So we are starting to understand how the cancer, when it comes back, what parts of the pelvis it comes back in. And this is a study that was published in 2008 from MD Anderson. They looked at patients when the cancer came back in the pelvis where it did come back. And what you can see is that the majority of cancers do come back in the very low part of the pelvis. Again, this is the leg on the other side. This is low, this is high towards the head. Very few cancers, actually, of all recurrences, only 7% are in the high pelvis. Yet we routinely treat patients to the high pelvis. So one of the things that we're going to be looking into in the next couple of years is, do we really need to treat all these targets up there that traditionally we have been treated? It becomes even more important because most of the small bowel, which is one of the organs that suffers most of the damage from radiation therapy and is most problematic, causing side effects such as diarrhea, do live up there in the upper pelvis. So if we could only treat the lower pelvis where the cancer comes back, maybe we would improve the therapeutic ratio, that is, how well this treatment is tolerated. And finally, can we identify patients who do not need radiotherapy at all? And there is a group of patients, those who have T3 disease, that is cancer that have gone through the wall of the rectum but have no nodes, or T2 that only involves part of the wall, that have gone into the muscle of the wall and have some nodes. This is sort of an intermediate risk group. And the question is, can some of these patients, or all of these patients maybe, be spared radiotherapy altogether? And currently there are two trials that are looking at this thing. One is in Europe. It's run by the Royal Marsden in Europe. And the other one is here in the United States, and we're just now opening this second trial at Penn. And the question would be, patients who would go on that trial would be at random allocated to either receive radiotherapy or not receive radiotherapy, just chemo and surgery. So I don't want to make it more complex than this. I think I'll stop here, and I'll probably will just join the panel, see if there's any questions.
Questions, please. Nancy?
Can you hear me? Is this on? Great. Okay, so the first question is actually probably for you. I had two, if I can have two. One is a lot of people have irritable bowel syndrome. Can you explain what the difference is between IBS and inflammatory bowel and what the risk factors for colon cancer for each?
Sure. Irritable bowel is what we generally refer to as a functional disorder. In other words, there is no chronic inflammation in irritable bowel. And because the names are sometimes confused because of IBS and IBD, which is sort of the shorthand for inflammatory bowel disease, which includes Crohn's disease and ulcerative colitis. In chronic inflammatory conditions of the colon, in particular ulcerative colitis or long-standing Crohn's disease that affects the colon, that chronic inflammation does increase the risk over time of colon cancer developing. So the risk of colon cancer developing is present in long-standing ulcerative colitis, especially ulcerative colitis that involves the entire colon, and in long-standing Crohn's disease, in particular Crohn's disease that involves the entire colon. But that is not the case with irritable bowel syndrome, where there's not chronic inflammation. So they are distinct in that regard. Generally speaking, the risk doesn't begin to increase until a patient has had the disease for 7 to 10 years. It's generally considered time to start doing colonoscopy on a regular basis when the patient's had colitis involving the entire colon for at least 7 years. So in the early years, that's not considered a big risk in IBD. But again, with IBS, it's a non-issue. There's no increased risk of colon cancer in that particular setting.
Okay, thank you. Can I ask one more? I think this is for Dr. Blyer. In the laparoscopy, do you know ahead of time that that patient is not stage 4? And do you have the ability to go in there and see, look at the other organs if you're treating a patient with stage 1, 2, or 3 to see if other organs have been impacted with the cancer?
Before we operate on anybody, we do what's called staging, and we do our best preoperatively to determine what stage they are. Using imaging and laboratory values, we try to determine ahead of time whether or not they're stage 4 by looking for metastatic disease, usually with a CAT scan or a PET scan. When we do laparoscopy, the first portion of the operation is simply putting a camera in and looking around. And so one component of that is trying to determine whether or not there's been any, spread of the disease that was not visible with our preoperative staging workup. We do have the capability to look at the liver and laparoscopically do ultrasound if we think that there's a risk that there's something going on that we need to determine, and we can do biopsies laparoscopically. But in general, we've determined before surgery whether or not somebody has stage 4 disease. Often if somebody has stage 4 disease, we start treating with chemotherapy first before going on to surgery.
Thank you.
I think Michael, is that Michael, I'm sorry?
Yeah.
Yeah, I have a question for you. Is ablation the same thing as hypothermia or a form of hypothermia?
Not in kind of the sense that you're thinking, I guess. We do, we're not lowering body temperature or anything. Ablation is going to be extremely targeted and extremely focused to like a 3 centimeter sphere. maybe 4 centimeters, and that's actually, you know, it's extreme kind of hypothermia in the sense that it's lowering the temperature, but we're really creating an ice ball, and that ice ball is kind of an environment that it's, you know, impossible for any cells to live in. So, yeah. Now, that's kind of a similar theory. We're raising the tumor temperature to 100 degrees Celsius. So now we're talking, you know, above boiling, 212, 215 degrees Fahrenheit. In that kind of 3, 4, 5 centimeter sphere. And that is what's making, you know, that's, you know, as kind of crude as it sounds, that's cooking the tissue. And yeah, so that is exactly what we're doing, but it's not kind of a systemic or body-wide process. But yeah, within that it's extremely targeted zone, that's exactly what we're doing. And that is, like I said, cooking the tumor. And if it's small enough, we're hoping to get, you know, surgical-like results, and we often do if it's small enough. That I don't know about.
You know, we heard about how it's used in a very focused way to target a tumor, to actually, in fact, burn the tumor. There is one setting where we will administer chemotherapy that's been heated to higher than normal temperatures, and that's following a very extensive surgical resection of intra-abdominal disease, so mostly disease that's coating the membrane that covers the bowel. So they go through a very extensive surgery, and then chemotherapy is instilled, and that chemotherapy has been heated. But we haven't looked at doing whole body hyperthermia as a means of treating the cancer. So that I'm not aware of any studies looking at.
Right. Okay. Yeah, it seems like we're just talking about body-wide versus extremely targeted, but it's the same idea.
My question is directed to Dr. Janov. Okay, you talked about the acylplatin and the 5-FU causing neuropathy. My greatest fear is I already have neuropathy. Will that increase it, and will it be more of a permanent issue for me?
So the oxaliplatin can increase existing neuropathy. It's done on a different mechanism. So if you're diabetic and you already have trouble feeling your hands and feet, your toes, and you're having a hard time walking, then perhaps oxaliplatin needs to be given very, very carefully, if at all, to reduce the risk of things getting worse. It's not the same mechanism of damaging the nerves. So theoretically, we could give some oxaliplatin because it is an effective medication, but we'd have to be very, very careful because yes, absolutely, it can make things worse and cause more trouble than what you're already having. So but it's a different mechanism of action, so it's different. You don't necessarily have to get worsening neuropathy if you have diabetic neuropathy and you're getting oxaliplatin. It's one of those risk-benefit evaluations that we have to make when we talk to you the first time around, because it is a very effective chemotherapeutic agent. It kills cancer cells, and if you're dealing with a situation where you're potentially curing somebody by getting rid of metastases, microscopic cancer, what's more important? A lot of times, if somebody already has pre-existing neuropathy, we'll say, you know, it's just not worth the risk of making it worse, and it's in your best interest to have less aggressive treatment with fewer side effects.
Okay, well, my neuropathy is from nerve damage, and then later I developed diabetes. But that's why it's good to have a dialogue with your doctors then, right?
Absolutely. It's really, really important that you sit down and say, okay, these are the potential benefits, these are the known risks. What happens if we make things worse? Are you going to be bedbound because you cannot walk? Is that worth it? So our goal is not to just kill cancer cells. Our goal is to keep you around as long as possible with the best quality of life possible. And sometimes the dialogue with the doctor is what it takes to make sure that we're achieving the goal that both you and the doctor feel is achievable.
Okay, so would that be year-round? Because I have it year-round, but not as aggressive as in the winter.
Is that the oxaliplatin one?
Yes.
Yeah. So the oxaliplatin neuropathy is made worse by cold.
No matter what season?
It's a temperature, the temperature of the air or the temperature of the
Or
object
whatever
you're
you
touching.
touch.
So if you
Or drink?
touch, drink, breathe in, all those things can be made worse with the cold, whether it's having a cold glass of lemonade in July or just going outside and taking a deep breath of air in January. So it's the cold, it's the fact that your nerves are being exposed to the cold through your skin. That's the problem.
Okay.
And it's an unfortunate side effect, and you and your doctor have to decide whether the goal of the chemotherapy is worth the potential toxicity. It's not it's not a yes or no question or answer. It's a dialogue that has to go ahead between you and your doctor, and it has to be an ongoing dialogue, not just a one-time deal, because things change.
Okay, thank you.
You're welcome.
I just want to know if is FAP the same thing as Gardner syndrome?
Gardner syndrome is a type of a manifestation of FAP, so they are related. Gardner syndrome is when you have FAP, but also have manifestations such as desmoid tumors or tumors of the jaw. So Gardner syndrome is a type of FAP.
I have Gardner syndrome.
Have you had surgery?
Many.
Thank you so much. If there are additional questions, there is another session scheduled for this room now, so we'll break, but if you have any questions, please feel free to come up and speak to any of the panelists. Thank you.